I think we should be good to get started. Hi, everyone. Welcome to our ROVER session on AI and machine learning. We're very excited to have three very prestigious speakers here. So if it's okay, we'll just get started by first having them introduce themselves. Maybe we'll just go in the order on this slide here.
Hi, I'm David Scher. I'm a head and neck radiation oncologist at UT Southwestern. Really passionate about incorporating AI into trials and using it to improve the precision of our treatments. Really happy to be here and chatting with everyone today.
And my name's Kyle Ostergren. I'm the sales director at MIM Software for our radiation oncology portfolio of products. I've been at MIM for about 15 years. So some of you, I've seen some names that I think I've run across before. So pleasure to be a part of this talk.
Hello, good afternoon. I'm Osama Mohammed. I'm a prostate radiation oncologist from MD Anderson. I'm also very excited to share with you some of the data we have had over the past few years in prostate cancer and AI.
Awesome. Thank you so much for being here. I'm very excited to hear your talks today. My name is Ria Mulherker. I am a PGY4 resident at UPMC in Pittsburgh, Pennsylvania, and I'll be the moderator for the session. So if it's okay, we'll start with Kyle's presentation, and I'll be advancing the slides for all of the speakers, and we'll try to keep it to around 15 to 20 minutes per speaker, and at the end of each speaker, we'll leave some time for questions. So for those of you in the audience, if you have questions at any point, feel free to type them into the chat, and we'll address them at the end of each speaker.
Great, thanks, Ria. I think, while I am the lone vendor here on the call, I'm really going to be speaking towards more of experience that we've had with customers and trying to integrate on the clinical side AI auto segmentation into their treatment planning kind of pathway. And I wanted to start by talking through just a few high level kind of what are the essentials within auto segmentation, specifically using AI. I think it's obvious that we want to make sure that we have high quality contours, but there's other components that need to be kind of considered as a center is kind of looking at their clinical workflow and adopting AI autoseg into to the kind of the regular contouring process. Things like how do we want to process the cases? What type of control do I have over the initial results? What visibility do I have into the process? And so as I go through the subsequent slides, you're going to kind of see exposing various ways in which you can have control, how you're automated, how manual is the process. And then ultimately, at the end of my time, I'll show you a few cases that our product, Contour Protege AI Plus, has generated, and just the raw results of that. I think when we talk about contour quality, there's two main components that from an engineering and really development product perspective that need to be considered is the access to the data as well as the algorithm that's training the data. I think most of the time, the algorithms side of things is pretty well developed. It's the struggle is oftentimes how do we get access to data? How do I get access to the right data to make sure the underlying elements of the training data are actually accurate and consistent, and then able to produce results, on a clinical basis consistently. So one of the things that I think we emphasize at MIM, and I know other vendors do as well, is when you look at the OARs that are created, making sure that those are coming from a clinical perspective. Same with from a dosimetrist perspective. Same with the lymph node chains that you're going to see in some of the cases that I show. That physicians are the underlying kind of generator of those structures. But I think beyond that, it's important to note, and we've learned from some of our mistakes over the years and learned from some of the successes, along the way, that when we bring data to the table to train a model, that data, underlying data needs to be contoured consistently. I think there's some underlying assumptions originally, and even in the MIM ecosystem years ago, that, well, if it was good enough to treat, it's good enough to train, and that's not necessarily the case. And I think that's a fallacy that we learned real kind of the hard way in our initial version. We struggled with some of the quality, and building a set of data that's very consistently contoured brings expert results. From a high level, making sure from a quality perspective that what is output, but when we train models before you get it into a clinic and you're using it clinically, we want to make sure that we assess that against gold standard contours. And so that's something that we've instituted in our process. Every version that's released goes through a very rigorous process to make sure that the quality is there before it gets in the hands of customers. I think that the next element is like, how does this process work in the framework of the clinic, right? So various vendors do various things, right? So I'm not here to speak to other vendors, but I am here to talk about my experiences working with customers. Ironically, because there's so many different AI vendors in the AutoSeg space, there are a lot of customers that have multiple vendors, and maybe even some of you on the call might have access to our AI, might have access to other vendors' AI. So one of the ways that you can process AutoSeg is through kind of like importing the data, telling the system to generate contours, looking and reviewing those contours, and then getting those into the treatment planning system. What that does is that provides you with a decent visibility into the process, but you're really spending time manually doing that. You can go to the next slide. The flip side is kind of more of like a fully automated process where it's kind of black box, for lack of a better term. The CT comes in, data gets generated, it outputs it either into a folder or into another system. What happens inside that box, there's not a lot of exposure for you as a clinician or as a center to really control what's happening inside of that box. Go to the next slide. Yep. So I think where MIM has ultimately been able to provide some value to our end users is the ability to have kind of the best of both worlds, where we kind of open the hood, as it were, of the AI kind of back-end processing to make sure that the contours that are being generated are kind of post-processed in a way that you would expect. But once that's kind of configured and set up, you can do it either where somebody manually launches it, or we have a kind of a zero-click process where you can have MIM and Protege identify the disease site that needs to be contoured, generate those structures, tailor the post-processing based upon the setup, and then we can drop that into MIM. A lot of our customers prefer to do their contouring edits in MIM, or we can, for example, with Eclipse, toss that into Eclipse and bypass the import so it's in the patient's active course of treatment. So the way we've built our product is recognizing that there are a lot of different components and different ways in which folks will approach AI and trying to make sure that we cover all of those scenarios. What I think is helpful in the framework of AutoSeg is that your goal is to save time and to build some consistency. I think those are the two main elements. And so I wanted to at least show you all a study that was done by Ochsner Health that looked at how much time does it take for us to edit contours that in this case Protege generates. And so the way that it's set up in that kind of top right hand corner where it says at the time of sim net zero processing time, what the way that Ochsner has it set up is that the CT sim comes into MIM automatically identifies that disease site, generates the structures, and then drops it into Eclipse in the patient's active course of treatment. So whatever processing time takes, which is somewhere in the 3 to 5 minute range, that's not time that they're doing anything. They're working on other patients, and then they open the patient in Eclipse, and there's contours there for them to begin editing. So on average, it's taking about 7 minutes for them to generate or edit the structures to get them to completion. One thing I want to note real quick, you can see there on the left-hand side, the prostate is elevated. That's because we currently, version's coming, but we currently don't separate the small and large bowel, and that was taking them pretty an excessive amount of time to separate those out. And so that's coming in a future version where they're separated and they won't have that editing, and we're anticipating that time to drop down. I mentioned a little bit at the beginning, just kind of tailoring your setup of MIM or of any system for that matter. And so I think it's important that whatever system you incorporate into your clinic has the ability to, and empowers you to have your own naming conventions, your own contour colors, the codes that you use, and that integrates seamlessly into the treatment planning system, or systems for that matter, that you might have access to. A lot of what sites do when it comes to MIM and AutoSeg is MIM drives the pipeline, and in some cases they have their, if you're an academic center, you might have your own internal AI complementing what our system doesn't have or another system doesn't have. And the question becomes, how do I make sure all of that stuff gets kind of in front of the clinician? And MIM can do all of that in the background. So, just calling that out, that like it's not as simple as just getting contours. You might have multiple systems. You might have things that you've done that your team in the lab has done. Now we need to implement that in a clinic. There are ways in which we can do that, and that ultimately bring value in making sure that you get the right contours that with the right level of accuracy into the clinic. Another common question is, how do we implement AI into a clinic, into a clinical workflow? What's the IT infrastructure requirements? These are questions that, when you're considering different options, it's important to know what is the answer to those questions at the vendor level. Quality is important, but you also have to understand the infrastructure requirements. So, some systems allow for a local installation on-prem, powered by a local server. That obviously increases the hardware costs, but from a security perspective, it's behind your firewall, everything's secure. The flip side of that is more of a cloud-hosted solution, where you might be able to get things done much quicker, because cloud can throw, in a cloud scenario, you can throw as much hardware as you want, cloud computing power at the process to make it go as fast as you possibly can. But again, from a security perspective, depending on what IT and IS would allow, that may or may not be doable. In the MIM world, we allow for both. So you can have a local installation, and I have sites that do that, and there's benefits to them for that. But then there's also benefits to minimizing the cost and the effort and just using a cloud-hosted solution. I think besides showing some cases, this is my last slide. So I'm going to highlight just kind of where are we at now, and I'm going to show you some of those cases. Right now, MIM offers CT-based AutoSeg for the head neck, for the thorax, including the breast nodes, the abdomen, the pelvis. But we're actually very close to releasing additional models that are brain related, as well as other CT substructures or structures to other models. So MR brain, liver, pelvis. We currently have a male pelvis. Obviously, removing the male anatomy can be applied on a female, but we're actually training a female pelvis anatomy right now. That'll be out very soon. And then additional abdominal structures that aren't there. I already mentioned the small and large bowel, heart substructures, things like that. And then I think the last component that I wanted to make sure I highlighted is some of you might have used Protégé or use Protégé today in your clinic. We are working to offer support from a GPU perspective for local installations, so that you can get contours in seconds rather than minutes. That's something we expect to come out later this year. For cloud computing, we're working on infrastructure changes that will take it from taking a couple of minutes to less than a minute to process in the cloud. You still have the up and down, right? You still have to transfer data up, get it back down, but the processing in the cloud will be much quicker. So Ria, if it's okay, I'm going to just go ahead and share my screen real quick.
Yeah, absolutely.
Great. And I'm just going to show you a few examples. These are raw results from Contour Protégé AI Plus. I've loaded them into MIM. I haven't made any edits to these structures. So what you're going to see are things that might need to be edited. We're live process. You're going to see some decent areas. You're going to see areas where we need to make some changes. You can see on the left-hand side a list of those structures that are there. I'm going to scroll through and just show you. You can see that list from the head neck perspective. So just scrolling kind of in the superior direction, then we'll go inferiorly. And obviously, at this juncture, Ria, if there are questions, I'm happy to answer them. I know you said you wanted a few minutes of questions before we move on to the next speaker, but just to show you some of the results, you're going to see the lymph node chain. One thing I wanted to call out is that because you have the power within our system to be able to control the output, we've had many clinicians that on the from a physician perspective, want the lymph node levels combined together, want left and right chains just one chain. They don't want them to be all separated out. So we train it separately because that's the standard that we follow. But what you see at the end would be one chain on the left, one chain on the right, and you can edit those accordingly. And I'll show an abdominal case as well. So you're going to see areas where you might need to make some changes, some areas where there would be some edits that would be made, but overall does a pretty solid job. And just as I mentioned in the one slide, time savings, we're seeing somewhere in the 70 to 80% reduction in contouring time. All right, I think I'll leave it at that, Ria. I'll hand it back to you, and then we can go over questions. And again, happy to do offline with anyone that wants to see it kind of personalized.
Sounds great. Thank you, Kyle. I'm going to go ahead and reshare my screen here. And I didn't see any questions in the chat. So if anyone in the audience has questions, feel free to type them in. But I actually had a question for you, if it's okay.
Sure.
So my understanding is that the AI portion of this is training the model on data in MIM, and then that software, becomes available to the institution. Is there any ability for more learning to happen from the tweaks that are made to those contours within the institution?
So what you're essentially asking is, can we create a custom or tailored model based upon either our data or the edits that we're making to your underlying data? Can it learn from that? And the answer to that question is technically we can do that. So it's not a technical software issue. It's really an issue of resources on our end and also of FDA clearance. So the FDA has been very rigorous in approaching custom or creating custom or tailored models by institution or changing the results after the clearance has happened, right? In other words, like we got clearance for the contours, and then now all of a sudden the models are evolving and are changing based upon additional inputs. They've been pretty clear that they're not allowing that. So the ultimate answer to your question is maybe under a research setting, something like that could happen, but not in a clinical scenario where we're selling it to you and you're doing that, if that makes sense.
Gotcha. Yeah, that makes a lot of sense. Thank you so much for clarifying.
Sure.
I do not see any more questions in the chat. So if it's okay, thank you so much, Kyle. That was fantastic. I certainly learned a lot. And thank you also to MIM for sponsoring this whole session. I forgot to mention that at the beginning, but we really appreciate it. And so thank you again so much for your time. And moving on now to our next speaker, Dr. Scher.
Hi, everybody. Thank you again for the invitation to talk with everyone today. I'm excited to chat about these various papers and ideas. If you go to the next slide, I do have to mention I did receive some research funding from Varian, and we have a patent pending for the work. That really doesn't affect what I'll be presenting, but is involved with it. So if you go to the next slide, I mean, I think that this is the real world, right? Like you have something in AI, like, and they actually showed you, like Mim just showed you, they have like a real black box probably sitting somewhere in their offices, and we just see what comes out on the end, the output, right? We kind of know sort of what goes in the input. We kind of see what comes on the output, and we're expected to use that, or at least interpret sort of some results and use that in some clinical way. And it's very uncomfortable for physicians, or at least it probably should be uncomfortable, because we want to understand how and why we have the information that we do. And so, when you see a paper that comes out, and they're coming out all the time, right? It's exponential, the number of papers that are discussing, this AI model, whether it's contouring or it's dose prediction or it's outcome prediction, et cetera. Like, why don't we just use it? And the reason is because, you really do need clinically, just like you have a new innovation in a clinical treatment, you have to prove its superiority in some way. And that superiority can be diverse, right? It can be, you can have better diagnoses, it can have better survival predictions, and you can then stratify patients better, et cetera. Or you can improve efficiency. I mean, all of these things are okay, but unless you really show it, a lot of it's just sort of papers and sort of vaporware. And that gain in the real world, which has cost, right? It has physical cost, like you have to pay money for it often. And there's also like just infrastructure cost often for being able to incorporate that. And so just as any new tool needs to be brought into the clinic prospectively, I would argue that we have to do the same thing with AI tools. And so if you go to the next slide, the question is like, where do we go wrong? And I think that there are some basic sort of concepts and uncertainty that I think make intuitive sense, and they've been articulated. So one of them is that you just aren't modeling the real world. So, this is called epistemic uncertainty. So, you train a model on, X, Y, and Z, but you're testing it on A, B, and C, and you just didn't really model the right data set, whether it's an imaging set on using just a different kind of imaging tool or imaging modality, and you're using it on a different one or one with different characteristics. There's sort of just uncertainty in the model. You also have noise, right? And whether it's imaging, I think in Radonc we use a lot of imaging, but there could be just junk. There's artifact here, and how you manage that artifact and how that artifact can influence your outcome really needs to be quantified and understood. And most importantly, it's us, it's the user, and how we as the user interpret the data, and how much we both trust it and are able to change our process based on any kind of AI output. And I'll show you different aspects of this. So I'm a firm believer in testing these prospectively. I think ideally we do it in a randomized fashion to really try to prove the efficacy in a way that we know, like all other clinical innovations or interventions. And that will tell us whether what we're studying and developing and validating is ready for prime time, or whether we actually have to optimize it first, or go back to the drawing board and understand where the uncertainties drove us to a bad place. Go to the next slide. And so here's a really kind of classic example of uncertainty. So this was a this was a study in which the gastroenterologist trained an AI model to identify esophageal cancer based on EGD, right? And it looked great. So the diagnostic accuracy was 83%, and versus 78% for humans, and maybe that margin is not so great, but it was better, right? And so they powered a study in which sort of a self-controlled, right? So the endoscopist recorded his or her diagnosis, and then they did AI, and they compared them, right? So it's a big study, almost 400 patients. Go to the next slide. It started off kind of reasonable. I mean, it looks like it was more sensitive than us, which is I guess is important, but it wasn't as specific. So they really weren't nearly as good. The AI wasn't really nearly as good in identifying non-cancer, and so the overall accuracy was less. It was 81%. Let's go back one slide. Yeah, sorry, 81% versus 86%, and they concluded that the AI it's not inferior. So actually it was worse than humans. And the reason, now you go to the next slide, please. The reason is because they started using different model, like they trained it on a different model set. So the training was on compressed images, but the real world model used non-compressed images. So it was like fundamentally different. You're looking at different, it couldn't interpret the non-compressed images. And the prior probability of disease was different. These patients had fewer lesions. So, you're going to have the negative predictive value to be more impactful because you have more negative lesions. So this was an example where both the model itself as also the patient population in which you tested it really showed you that, the raw operating characteristics, the sensitivity, specificity, what makes you think it's solid and usable actually in practice was not. Go to the next slide. Here's another one which speaks to us, and I think we'll all sort of understand, like everyone has that attending, right? Or that colleague or that friend. So this is a really nice study from Princess Margaret where they developed a machine learning based planning for prostate cancer. And then they prospectively evaluated, and you can see on the next slide how it was a very nice sort of, and I think natural progression, right? So they developed their model, and then they did a retrospective evaluation where, you had, comparing, the docs were comparing the machine learning versus the human, plan. And then they did the same with, prospectively, ML versus human. And then the idea was to then, just use machine learning. And so they did this with 50 patients each. And in terms of like raw efficiency, this was a huge win. No disrespect to Dr. Muhammad, but I didn't think prostate cancer planning was this complicated, requiring 150, what is it, 100, many hours, 115 hours. I don't know what that was about, but regardless, you can see how it improved the efficiency of their planning dramatically when you had machine learning plans, and for whatever reason, this makes sense. There's a lot of iterations you go through, like asking the doc, going back and forth, tuning structures, etc. And they were able to save 71 hours. Whether it's real world, I don't know, but it's a number, and I think we would all agree that a machine learned plan where you kind of almost take the dosimetrist out of the equation is going to be more efficient. So the question though is what happened in practice. So if you look in the upper left, the blue is essentially the retrospective, sort of what would happen in principle, and then the green is when it was actually used in practice. And all of a sudden, the machine, once it was actually really had to use it, the doctors were less likely to use the machine learning plan. And that's even if, on consensus, they had a group of doctors saying, okay, this is a good plan, or this is the preferred plan, even if it was the better plan that should have been selected. So if you look on the bottom left, the 92%, that's sort of the better plan by consensus review, and almost all the physicians chose that plan. But once it was deployed and there was like, actually, maybe I'll be using this plan on a patient, even though, again, these plans were considered the better plan, only 71% of them were used in clinical practice. And this tells you how the interface between the AI, the box, and the physician is so critical. And there's that attending, number 5. So if you go to this graph here, they could tell which plan was which, right? And you always know, you have different nuances. I mean, you can kind of, as a physician over time, figure out, but who the planner was, and sort of probably the characteristics of an ML plan. And that's what happened. And so like planner 5, clearly preferred the human plans. And he was also very good at predicting which one, if you go up a few lines there, he was also very good, and in fact, he selected the better plan less often. I shouldn't say he, I don't know who it was, the person. And when I was in Toronto a few weeks ago, and I sort of asked them about this, and yeah, they knew this was going to happen because there's so many preferences. And so it speaks to go to the next slide, it speaks to the importance of developing this with clinicians. And so this is exactly sort of what the point was. So the preference from the human plans, this is a quote from the paper, and if you go to the last line there, it says, these results highlight the impact of physician preference and perception on validation results. And it really highlights the importance of bringing this into the clinic, like as a clinical study. And number 2 is the importance of physicians. And it's not just, being able to program and understand Python and all this stuff. It's much more sort of the clinical skill and insights that we have as physicians, and being able to then translate that to your colleagues who are doing some of these models to be able to use it and optimize it. Now, this is sort of my own sort of case, so to speak, where I've been really passionate about this. Has been sort of a lot of my life over the past 5 or 6 years. And as everyone knows, elective neck irradiation is a core standard tenet of head and neck radiotherapy. This is just how we're taught and how every standard case is done, and that's because there could be microscopic disease and lymph nodes that aren't obviously seen. Got to sterilize that. But this dose is really a lot of the toxicity, right? I mean, the elective neck irradiation field borders your salivary glands, borders your swallowing organs at risk, all that stuff. And so really focusing on optimizing ENI can be a big gain, with quality of life, and moreover, potentially less risk than dropping total dose. And so I feel like ENI in general, and this is, I think, a general scheme across both the US and Europe, they're really trying to optimize it. And so our goal at Southwestern was, through a series of studies, to go essentially from, an elective neck field, which is the blue here, and you can call whatever dose you think should be done there, and drop it entirely, and just treat the lymph nodes that are there. And here you kind of have, gross cancer that's like screaming out at you, I'm a malignant lymph node, but also the suspicious nodes, or the nodes that harbor cancer, that are the ones you're treating with ENI for. And the question that we faced when trying to drop ENI entirely is, how do we identify those nodes? These little guys, little suckers that don't have any gross malignant appearance, but could carry microscopic disease. And so we thought that AI was going to be a really ideal solution for this. If you go to the next slide. And so we, from the beginning, wanted to figure out what's our gold standard. And I think, just like Kyle was saying, the gold standard is extremely important. It is actually one of the most important, because if you're modeling a bad outcome, and actually that's true in many different domains, right? As there's accuracy, like whether it's good or not, there's disparities issues and biases and things. That what you're modeling, that gold standard is extremely important. And so we were tempted to use sort of radiologic criteria, but in the end wanted to use what we think is the best ground truth, which is pathology. So we identified, go to the next slide, 130 patients, over 700 nodes. I think in the end there were more than that, and tried to correlate the preoperative appearance of the adenopathy, contoured all of them, and then correlated them with the pathology result. And I won't forget, because it was just like I was driving, it's like 6 years ago, I think, at this point, and there was an intern, or a rising intern, I think, who was going to join our residency, who was like really passionate about this. And so we worked together, and that was like 6 years ago, and now he's my colleague. And it's been just a great experience sort of working with, junior trainees and seeing them sort of mature. And we worked on this really closely together and tried to sort of basically pick out, okay, this node is this and it's negative, this node is positive, and so on. And it's not easy. And we actually left a lot of money on the table, because if you couldn't tell exactly what it was, we didn't want to be wrong. And so there's a lot more nodes, obviously, in 129 patients than 700, but we wanted to be as accurate as possible. Let's go to the next slide. And, the model looks pretty good. And I'll show you the operating characteristics in a second, but basically, because not every patient had a PET CT and it was biased, the PET CT patients were biased as oropharynx, because a lot of times the laryngectomy patients, don't have a PET beforehand. We had a couple of different models. And you can also imagine, just, for those who've done head and neck rotations, oropharynx nodes, like P16 positive HPV nodes, they look different, right? So we ended up having 3 models. The PET was the biggest one, because it was all patients, actually, and then there was a CT only model for both oropharynx and larynx. And you want your ASC to be super high, and we achieved 0.92, which we're really pleased with. Now, when you go to the next slide, you'll see that our operating characteristics were really satisfying. So the model produces a number, right? It's the probability of disease, and we said, okay, we're going to treat this thing, we're going to consider this positive, it's 50% or higher. And that was sort of arbitrary, but it was in the model designed to optimize the sensitivity and specificity. And, if you just as an example, look at the combined model, I mean, our sensitivity is 93%, our specificity by definition lower, because, we didn't want to miss. And so we're more willing to call a negative node positive, but because most nodes are negative, actually, while our positive predictive value is 61%, it's not terrible, not great. Our negative predictive value is very, very high, right? So if you call a node negative, you want that node to be negative and not miss. And so we kind of optimize the model in this way, and tuned it specifically, so we would have a high negative predictive value. And if you go to the next slide, this was the the engine for our trial, our first trial looking at this, called inert air, involved nodal radiotherapy using AI based radiomics. And we thought, or at least the residents thought, that this would make life much easier, because you don't have to do elective neck, right? This is before MIM and Limbus and all these companies could just do it for you, and in fact, it was the exact opposite. It was so much work, because the average and the median was like 30 nodes. So you're contouring these little suckers like up and down the nodal chains, and then we would submit them to the model. And I'll just tell you, I don't know if it matters. I mean, I don't know. You just do it, right? You don't have any pathology from it. But every patient, almost every patient, had a node, and so it really would have changed what the volumes were going to be. If you go to the next slide. The basic regimen, just to sort of give you some reference, it was 70 and 35. I'm not sort of doing anything crazy with the total dose. This was all patients, oropharynx, P16 positive, P16 negative, larynx, hypopharynx, everyone. It was elective volume around the primary, and then all these suspicious lymph nodes received a high dose. Like, I admit, it was a high dose, 66 gray, and it was 66 gray because did not want to miss. You can give something 56 gray and it can grow through it, and it's not the fault of the model, it's just too low. Didn't want to go down that road, wanted to make sure that we're not missing anything that's getting no dose. So we did give admittedly a higher dose. If you go to the next slide. The way in which it actually worked, make sure I'm still on time here, was by having a very clear set of criteria in order to define something as suspicious, and then getting this intermediate dose. One of them was size. We had heterogeneous enhancement. We actually would treat the nodes that are in the same station as a grossly positive node, and then you would have the model submitted. And so you'd have basically this sort of pockmarked appearance, of the treatments, of the plan, the treatment plan, because you'd have different nodes in different places, and as you would imagine, they're kind of biased in the areas where you have the high probability of having disease. Let's go to the next slide. This study was very successful. So, we enrolled 67 patients, had no solitary nodal failures. It was a different experience of treating head and neck patients. It was great. I mean, the dermatitis risk was low. They swallowed great. It was really satisfying. And you can see, like, no disrespect to protons, but like, software can give you a lot. Software can give you a contralateral parotid dose of 13.5 and an ipsilateral parotid dose of 21 for your larynx or pharynx patients. And you can't even get that, with particle therapy. And so by using AI, possibly, but definitely using a novel scheme, with software effectively, you could accomplish some really, I think, satisfying dosimetry, and that was manifest in the patient-reported outcomes. that you see there on the right. I mean, these MDADI scores, which is sort of the MD Anderson Dysphagia Inventory, these are sort of like the gold standard for swallowing PRO. You know, this is better than HN002. You know, these are really excellent results. So go to the next slide. You know, when you incorporate these type of tools into clinic, you got to make them easy. You don't want people to struggle. I mean, me as the sort of the PI and one who's been invested in this, maybe I'd be willing to struggle, but most people aren't going to, and that's understandable. I mean, it's like an extra step, and so you got to make the tool really efficient, you know. And so what we did was we had an Eclipse API that just allowed us to go kind of like that. So we would fill in which are the nodes, you know, that need to be evaluated in the model. Which model is it? You know, larynx, hypopharynx. You know, where's the PET? You hit a button, this malignancy prediction button, and you would get an email that would come back. This one is positive. This one is negative. So it was really easy, and you know, it would come back to you within about 3 to 4 minutes. Go to the next slide. So, you know, this is the other piece that you have to do prospectively to understand where there's errors. So it turns out, as you probably know, that you don't do that much level 1B lymph node dissections for oropharynx or larynx cancer. So we never dissected the submandibular nodes, right? We never had that in our model. And so we had this sort of this epistemic uncertainty. And it turns out that the avidity from the submandibular nodes was bleeding into the lymph nodes in level 1B. And we had all of these positive 1B nodes. It was sort of devastating because you're trying not to treat those nodes, right? And so we actually had to change the protocol, but it was because we didn't model this. And it speaks again to how until you do this prospectively in a study environment, you're not going to understand where things can go awry and where you didn't anticipate something when you were initially generating the model. Go to the next slide. So, you know, there's a limit too, where like there's only so much information in a CT scan, right? I mean, these scans are, you know, 2-3 millimeters, but I mean, clearly there were things that are there that were not positive, and why they were, again, bleeding from blood vessels. There's only so intelligent, you know, that AI can be, and the flip to that is, you know, when you have a really tiny node, there's a limit to how much information it's going to be able to grapple out of that. Go to the next slide. And so, you know, we had some grant funding to do a next generation study. And basically what we did was take context into account. We took the difference between the primary site and the lymph node that we're studying, the lymph node's relationship to each other, you know, which level is it, things like this. And we're hoping that we can build a smarter model that sort of thinks more like a physician in terms of, you know, in terms of the likelihood of something being positive based on this prior probability. So go to the next slide. I think, yeah, so I know I'm a little bit past time here, but basically we did a study very similar, involved node paradigm, but we did daily adaptive radiotherapy, and all of the time, almost 75% of the time was spent with these AI nodes. Now, whether daily adaptive is a real thing or just, you know, a once in a lifetime kind of study, I don't know. But, you know, we spent the time on these little AI nodes in terms of contouring, and it speaks to the importance of getting it right, you know, and not just having a model that just says everything is positive because you don't want to miss. And you really do, especially with that sort of, you know, daily adaptive approach, need to have this as accurate as possible. So go to the next slide. You know, this one last sort of comment here on the unintended consequence of dentists, of AI, and you can see this with dentists. So basically, they modeled caries, right? You know, what's I think it was the typical, that wasn't Panorax, but the wing, you know what I'm saying, the X-rays you take for cavities, and you know. Then they gave the dentists AI as a tool to help. And most of the dentists did better. So if you look in the upper right here of the bottom box, the red is with the dentist. So their sensitivity went up, you know, and their specificity went up a little bit, right? So you want to kind of go up and to the left because you want to be high for sensitivity and you want your specificity to be high. And so that's to the left. But there was one dentist who got worse in both. So the dentist was poor to begin with, you know, and then with the AI, they became less sensitive and less specific, which is disastrous. Everyone has cavities, nobody has cavities, have no idea what's going on. And so the idea of the AI is obviously to make you more accurate, but the user is so essential to this, right? And some of that may have been the model, but it really just goes to show you how important the interaction between the tool and the physician and the clinician is. So my last slide, I'm hopefully not too far past my time, but you know, I think that these cases, both ours here in Dallas, but also these other papers, really show you that when you have a model, you have to test it prospectively. That's really crucial to show the clinical utility, also to identify any pitfalls or hazards. But that it's I think really promising, and I would really encourage all the residents here to really engage with your team, whether it's physicians or physicists or AI scientists, to think about this and think it's the future. So again, thank you for the opportunity. Look forward to any questions.
Thank you so much. That is super, super cool, that this project. I don't see any questions in the chat right now, but I have one question. And it's about when this model was built, So you contoured all of the nodes in the neck, and then did they have a lymph node dissection? And I guess, how did you work with the surgeon to make sure that you were correctly
Yeah.
correlating the node that you contoured to the node that was dissected?
Yeah. So our surgeons, 90 to 95% of the time say the level that the pathology specimen is coming from. So they say it's level 2A, level 2B, level 3, level 4. And so that's the first thing, is that you can really tell what the level it is based on how they labeled it. And so that's how you get oriented, in terms of what's positive and negative. That was the first step. And so the easiest ones are when a level was totally negative. That was money, right? So then, level 3 is negative. You can contour any level 3 node that you see, right? But then most of the time, there's like one node positive or two nodes positive. And, that almost always is obvious. Like obvious to a point that, you feel very comfortable saying, okay, I'm calling that positive. It's necrotic. SUV was 10, something that when you as a clinician are looking at it. And then there were times though that you couldn't tell. And you just didn't include it. You lost it, and it's disappointing because those marginal cases are the ones that you really want to model. That was how I think we preserved the accurate, the true gold standard. But yeah, it made it a little bit more difficult at times. And again, like that's why I say we would have 6 to 8 nodes per patient, but there's many, many more nodes obviously for a given patient. In our new model, we doubled the number of nodes. So we added like 30 or 40% more patients, but then went back again and tried to find more of them. So the small ones are the ones that are the most helpful for us.
Gotcha. Very interesting. Thank you for explaining that. All right. I guess, and thank you for providing your contact
Oh,
information.
sorry. Yeah, please.
And yeah, thank you so much. Moving on now to our final panelist, Dr. Mohammed.
Hey, good afternoon, everybody. Thank you for the invitation. And, I've known Dr. Sher for 10 years now, since 2014. And I was a resident with him. We had a wonderful time. So I don't have any conflicts of interest to disclose. I'll be talking about a little bit different than the prior two speakers. This is more related to traditional pathology and how it's evolving into computational pathology. As we all know, traditional pathology has dominated the field of medicine for the last maybe 100 years, but in the most recent decade, things have been changing. In traditional pathology, histology slides are prepared, they are stained, interpreted, and then physically stored. Data analysis is limited to the subjective visual inspection by the pathologist, and the retrieval of slides was very cumbersome. You can imagine if somebody wants to do a research project, you'll actually physically have to go pick up those 100 slides, 200 slides from the shelves and then look at them again. So collaboration was very difficult. Next slide, please. So comes whole slide imaging and computational pathology. Unlike the traditional microscopy workflow, digital pathology includes the process of digitizing slides using whole slide scanners, but also the analysis of these images using computational approach. It's a dynamic image-based environment, not only including image acquisition, but also storage, management, and interpretation of images. Thus, the whole workflow of pathology is changing. Next slide, please. And as you can see here, across the traditional oncology care pathway, starting from prevention to screening to diagnosis, staging, treatment, assessment of response, and follow-up, anytime there is a biopsy that could be done, which is mostly for digital pathology at the time of diagnosis, AI can have an important input into treatment decisions for patients. And for patients with prostate cancer specifically, AI can assist in cancer detection, in segmentation, in cancer grading, for example, Gleason scoring, histologic subtyping, specifically identifying what subtypes are in the pathology, such as intraductal carcinoma, expansile cribriform, but also biomarker quantification like Ki67, PD-L1 status, and also like predicting of genomic scores or genetic mutation. For example, you can tell whether there is a PTEN mutation or not. And finally, which is what I will talk most about in the coming few slides, AI can help in predicting the outcomes for patients and predicting response to therapy. Next, please. So the promise of computational pathology in prostate cancer is that it can improve the diagnosis of prostate cancer, improve the prognostication of prostate cancer, and also help us predict which treatments work and which don't. I will not talk about diagnosis because I actually have not done any work in that. So we'll talk about a little bit about prognosis and prediction of treatment benefit. Next, please. So AI as a prognostic tool. So very quick prognostic versus predictive biomarkers in prostate cancer or in any kind of cancer. A prognostic biomarker help us estimate the risk of recurrence or survival, and thus it help us personalize treatment decision. For example, if you look here, let's say we are looking at recurrence, patients with a positive biomarker will have good outcomes, no recurrence. Patients with negative biomarkers will have poor outcomes. They will have a lot of recurrence. However, if we look at the patients with positive biomarker, whether they take a certain drug or they don't take a certain drug, the graphs are on top of each other. There is no difference. Same for biomarker negative. However, predictive biomarkers are a little bit different. They actually will tell you which patient will respond to which drug. For example, in patients who have positive biomarker, they will do better with drug as opposed to no drug, whereas those who have negative biomarker, there is no difference. So a predictive biomarker is a biomarker that will tell you which patient respond to what kind of treatment. Next, please. So let's talk about development of a prognostic biomarker for patients with prostate cancer. With approval from Energy, we assembled a very unique data set actually from 5 large randomized clinical trials of patients with prostate cancer. Namely, they are RTOG 9202, 9408, 9413, 9910, and 0126. And these patients randomized patients to many different combinations of treatment, mostly radiation with or without hormone therapy and different duration of hormone therapy. We had about 5,600 patients and more than 16,000 slides and 16 terabytes of data. And we collected digital pathology from these slides. So they're slides that were already stored by Energy, and we collected these baseline clinical data, T-stage, baseline PSA, a Gleason score, and age. And then we built 6 models, and these models would predict at different time points biochemical failure, distant metastasis, prostate cancer specific survival, and overall survival. Each of these models was trained on 80% of these data, and then the models were locked and validated on the remaining 20% of the data set. So as you can imagine, this is development of this prognostic biomarker was not externally validated. This is internal validation of the same data set. Next, please. So this is, I'll take you over the workflow of how the model was developed. There was 2 pipelines for developing the model. The first pipeline is training on clinical data alone. So these 6 clinical features were fed into an AI model. The second pipeline was development of a digital pathology AI model, basically taking only the slides and the images and develop a model from these. And then the third pipeline is to combine both the outputs of these 2 pipelines into one AI model, and finally to use the score that you get to predict the 6 outcomes that I spoke about: biochemical recurrence, distant metastasis, prostate cancer specific survival, and outcome. Very important that these slides were not manually annotated. We used self-supervised learning, which does not require manual annotation, which is very time-consuming and very laborious process. Next, please. So before I show you the outcomes of the modeling and the findings, we were interested to see what is the model looking at to find its predictions, to predict, to give you the to give you the output. What is it looking at? This is our attempt to try to explain a little bit the black box of the model. We have two explanations. First, the model is looking at certain things that we look at. It's looking things that we can interpret and we can learn, like benign prostate glands, enlarged cribriform glands, blood vessels, smooth muscles. So the model is looking at human interpretable features, but also, and it's not shown here, the model is looking at some non-human interpretable features. It was looking at things, for example, in the stroma, in the microenvironment, which we don't look at, and we just don't know how to explain it. Next, please. So this is the model in comparison to the NCCN risk stratification tool. Although we developed 6 models, I'm going to focus on only 2 of these models, the predictions of distant metastasis at 5 years and at 10 years. As you can see here, the AI model did better in terms of AUC compared to the NCCN risk stratification tool at both time points. Next, please. So in the clinic, we use a lot prognostic models in our head. Basically, patients tell you, how long will I live? What's the chance of controlling the cancer? What's my cure rate? We always tell the patients, oh, you know what, you have unfavorable intermediate risk prostate cancer. Your chance of cancer control at 10 years is about 15%. However, what I have just shown you does not help me making a decision about the treatment today. Now, for example, if the model predicts 60% risk of metastasis, this is telling me that I need to intensify treatment, but it does not actually tell me what are the treatments that are important for this patient. And here comes the use of predictive models. Next, please. So we were interested in developing a model which will predict for those patients with intermediate risk prostate cancer, which patients need hormone therapy and which patients don't need hormone therapy. Up to this point, the standard of care was that if a patient have favorable intermediate risk prostate cancer, they need hormone therapy, and patients who have they don't need hormone therapy, and there's patients with unfavorable intermediate risk prostate cancer, they need hormone therapy. However, we know that this was very simplistic because we know that some patients with unfavorable intermediate risk don't actually need hormone therapy, and some patients with favorable intermediate risk do poorly. So we took, out of the 5 clinical trials that we used for the first project, we took 4 of them, and we created a predictive model to predict distant metastasis. And then we validated the model on the 4th data set, which is 9408, which is a randomized clinical trial which randomized patients, mostly intermediate risk patients, to hormone therapy or no hormone therapy. Next, please. So as you can see here, let's look at the overall population. This is all the patients in 9408. And you can see you have 2 graphs, an estimated risk of distant metastasis with radiation alone. Let's say at 15 years, it was 10%. Radiation plus hormone therapy, it was 6%. So you can imagine, just looking at all the patients on 9408, there is about 5% risk reduction of distant metastasis with hormone therapy. So it makes sense. Everybody with intermediate risk prostate cancer should get hormonal therapy. However, we know this is not the full story. When we developed the model and then we divided the patients into biomarker positive and biomarker negative, as you can see, patients with biomarker positive will have significant reduction of distant metastasis with the use of hormone therapy, let's say at 15 years, from 14% with radiation alone to 4% with the radiation plus hormone therapy. And those who have biomarker negative do not see any benefit. So this is, for the first time, you have a model which will actually tell you that some patients will benefit and some patients will not benefit, although the original clinical trial basically suggested that we should give hormone therapy to everybody. Next. And the same finding would be found with prostate cancer specific mortality. Next. So I will not go into a lot of details about the advantages or disadvantages and challenges with AI, because Dr. Sher has went through this in detail. But I want to get into one idea that I really like to talk about, which is the legal and ethical implications of developing an AI model. Let me give you an example. Let's say I see a patient with intermediate risk prostate cancer patients, and I give them hormone therapy for 6 months. The patient finished the hormone therapy, but they never recovered their testosterone. I have this fiduciary relationship with the patient. I made the decision to give the patient hormone therapy. So the patient, I have ethical responsibility for that decision. And the patient will come back to me and say, hey, like, you gave me this hormone therapy. I never recovered my testosterone. You are responsible for this. You destroy my life. Whereas let's say the patients come to my clinic and I use this AI model and I tell them, according to the model, you need hormone therapy, and the same thing happens. Who has the ethical responsibility for the decision? Can the patients go to the company and say, hey, you have ethical responsibility and legal responsibility for the decision that has been made? And this is really not clear yet, because we still are not using these models enough. They are not in the clinic enough to see these issues, but they will definitely come up in the future. Next. And this is, again, Dr. Sher spoke in detail about this, but it's very nicely modeled in this picture. Even if we develop a model, and we had a very nice paper that was published, but that model is very far from going into the clinic. The model not only has to be valid, which we can show in randomized clinical trial, prospective validation, internal, external validation, but it has to be useful. It has to be easy. It has to be efficient, and it has to work well with other systems in the clinic. But also it has to show utility. It has to improve survival, improve quality of time, improve cost effectiveness. And so from model development to clinical impact is much more than publishing a paper. Next. So this is a summary slide. Basically, there's a lot has been done, and a lot still that could be done to develop diagnostic, prognostic, and predictive model for prostate cancer and from many other cancers. And there's still, I think, in the next 10 and 20 years is going to be an explosion of these models. Next. A lot of people have worked with this. I'm very thankful to all of these people who helped with this work. Next. And thank you.
All right, thank you so much. These were all very, very interesting presentations. So thank you so much to all of our panelists, and excellent work with timing, because we're ending right on time. We really thank you guys for your time and for being here with us. And thank you also to our participants. This was a little different than our normal ROVER sessions, but the goal was really to expose medical students and residents to kind of the emerging roles of AI in our field. And I think, all of you very effectively laid out some really cool applications and also some very pertinent challenges that we as a field have to continue addressing. So thank you for that. And also huge thank you again to MIM for sponsoring this session. And looks like we have some comments in the chat, and they're just thanking everyone again for a great and comprehensive session. For those of you in the audience, this will also be made available on our website and on our YouTube channel if you want to revisit this. And everybody have a great weekend.
Thank you, everyone. Bye-bye.
Thanks, everyone.
Thank you.
Thank you.
Thank you.